infected knee replacement, as you're going to hear later, and I'm sure you already know, presents a major problem. So there's two factors I'm going to ask you to consider. There's the patient factors and the surgeon factors. Preoperatively, we know certain things are associated with infection, and some of those that we can treat, such as nutrition or obesity and diabetes mellitus. If the patient has it, clearly we can't remove it. And this does bring to question about patient selection. Should we be operating on the very obese? And what about people who smoke? Because we know that they are going to increase the risk of infection. And it's been shown that also you get a higher rate of infection in diabetes and hypertension, and the post-operative infection rate is higher if your BMI is greater than 35. And in the UK now, some of the commissioners are starting to insist that patients for knee replacements must have a BMI below 35. However, I think at one stage not so long ago it was suggested that people, if they had their knee replacements, they might lose weight. In fact, there's quite a good paper showing that they don't. So morbid obesity and combined with diabetes are certainly a risk. Rheumatoid arthritis carries with it a significant risk, as do previous surgical procedures, although previous arthroscopy does not. Skin conditions such as psoriasis will increase infection, and preoperative skin ulcerations obviously need treated. And one of the problems we have is those who have chronic conditions that it's very, very difficult to get the skin healed, and then if it is healed, we need to get at time of our surgery, and it's quite frequently the case that it's healed, and then by the time we arrange surgery, it's broken down again. So we can choose which patients we operate on. There's nobody we have to operate on, and so to a certain extent, it's the surgeon's choice. But once we start operating, things are also in our hands. What about gloves? Well, if you perforate them, you're much more likely to get the risk of infection. And we can look at the rates of glove perforation, and we can look at the site. And so the only thing we can do is try and buy good quality gloves that are not prone to tearing. The way we put on our gloves is important, and what gown we wear is important. And these are all things that the surgeon can choose. And we know that if you have a hood, you're much less likely to get infection than if you use simple simple hat and top. What about the operating room itself? Once again, I think this is within your control. You should not open the trays until about to use them. You don't want everybody walking around in the operating theatre, and the environment needs regular swabbing. Tourniquets haven't been given much thought in the past, but it's quite clear if you look at tourniquets, they are the source of infection, and they're very difficult to sterilise. And there's a good case now for using disposable tourniquets, or if you wish, don't use a tourniquet at all. I think the current trend is probably away from using a tourniquet for knee replacements. Don't open the trays until you need them. It may sound very sensible, but one of the problems is that someone has to check that what's in the trays is all there. If you don't open them early, you can't check them. Staples became very popular because they were quick, but they are associated with infection, and personally I don't use them. We can wash the wound out before we close it, and betadine lavage, simple and inexpensive. It probably helps, but because it's cheap and easy to do, I would recommend it. Bandaging the limb afterwards is a good way of producing pressure, stopping infection and oozing, and I would recommend it. What about after the surgery? Well, we know that these conditions are associated with increased wound infection, and the only one I'm going to draw your eye to is the urinary tract infection. It's quite reasonable not to operate on people who have a preoperative infection. And then the discussion about what sort of anaesthetics, and then if it increases the use of a catheter, urinary catheter, and urinary catheters are associated with infections. We need good nursing care. We need to teach our nurses how to manage the wounds, and I think in particular there is no need to change the wound just because a certain time frame has passed. If the wound is dry, there's no need to change it, and even if it's just a little bit moist, I suggest putting another one on top. Regular changing of a wound, every wound change is an opportunity to introduce infection. Well, what is an infection? We need to define it if we want to measure it, and it's at or near the operative site within 30 days. As I said, there's 3 major sources, and Staph aureus is probably the most common bug. The incidence of infection is probably a minor infection. I think that's probably a bit high, but it's certainly not zero. It's more frequent in total knee arthroplasty, and if there's a precarious blood supply. The best management is obviously to avoid any wound complications. If we get blisters, they're often associated with the adhesive on the dressings. They lead to infection and delayed healing. And the incidence of blistering is quite high in my experience. It's probably 10 to 20%, and it's often associated with trying to stretch the dressing on rather than just putting it on in a non-traction manner. And blisters come because of movement between the skin and dressings, and as I say, I think dressings have moved on. You need to have a soft dressing that doesn't stretch the skin. The best way to manage blisters is to avoid them, but if they do come, then I think we're best left alone unless there's a sign of infection. And I wouldn't give antibiotics just because they've got a blister. If you do have a wound that needs draining, because it's become a hematoma or you think it might be infected, don't wait. So prevention is the best way. Sorry about that. And if you get superficial skin necrosis, it does happen occasionally, particularly with difficult knees, where the skin's been undermined. This is a real problem, and I think it needs early intervention. Immediate debridement, and often they will need a flap, and this is what you don't want to see, prosthesis exposed through the skin. When closing the wound, we want to try and get maximum blood flow, but we want to minimize the bacterial contamination and dead space. Subcuticular stitches are best, and as I said, I would avoid staples. And I think to avoid hematoma collection, drains can be used, and I think heavy bandaging. Occlusive dressings, they're better to use them. They allow the reepithelialization, and that's better than exposing the wound to the air. I think the timing of dressing change is something that seems so simple, but I would ask you, don't change it just because a certain amount of time has passed. Every time you change it, you increase the risk of wound infection. How you close the wound is important, using a layered wound. So I always use a subcuticular closure and then put a dermal bond or a glue on the joint to prevent it leaking. This is the sort of wound you're looking for. It's almost dry, and if you can get that at sort of a week, you're doing very well. So the first dressing change can be 10 days, which is when you're going to take the suture out. It's got the advantage of reducing infection, and it reduces the pain associated with it. Because they're waterproof, obviously the patient can shower. Dressings can be left in place, and as I say, because they're clear, you can also see through them. Post-operatively, physiotherapy is important. There's no point, to say, sitting in bed waiting for the knee to work. The patient's got to work hard on it. That's what the physiotherapist does. And we know that physiotherapy will encourage wound healing as well as improving function. Adequate follow-up. You've got to look at the patients. There's no point discharging them day one and then ignoring them. And if you don't follow them up, you don't know how good you are. And that's where audit comes into it. We haven't necessarily measured our wound infection rates, but in England now, our personal infection rates are published, open to the public, and that, of course, is giving people cause for concern and making them give attention to all those points I've just mentioned. It's a team effort. Recognise it, and hopefully infections will be very low. Thank you.
Thank you very much. Any questions from us?
Scalpels, they create more infection than suturing.
Yes, and they're painful to take out. I think subcuticular stitch is the best way to close the wound.
You prefer suturing?
I prefer a subcuticular stitch where you run it underneath the skin so the skin edges can heal directly.
there any role of electronic vehicle assisted closure?
No. Well, I haven't used it. I couldn't comment for actually closing it. Very good for infections.
I think betadine prevents healing. Whether to use betadine irrigation?
I don't think there's any evidence that betadine lavage sort of prevents healing. But
Any role for the brains in a severely obese patient?
sorry, it's very difficult to hear.
Any role for the brain?
Any? Should you use them?
The question is, any role of suction drains in obese patients?
Oh, sorry. Yes, it's very variable. There's some people now who are not using drains at all. Good attention to hemostasis, putting adrenaline into the wound, and heavy bandaging. Others will put wounds in, and in obese patients, they will put a drain in the subcuticular layer. Personally, I think if they're very obese, I'd put a drain in the obese layer.
Thank you very much, Lawrence.
Thank you.
Just for my knowledge, would I just see a show of hands how many people in this audience use staples and how many use sutures to close their wound? For staples, I think the majority has sutures. Okay, one more thing, how many of us use autoclave to clean this? Thanks.
Thank you very much, Lawrence. What is the
One last question, okay?
How do you prepare pre-operating this operating site? Do you want immediate saving or applying some cream?
I think the question was preoperative skin preparation. The current protocol is that they have a simple wash on the morning of the operation, and then in the operating theatre we use a chlorhexidine in spirit.
Hair removal?
Shaving, yes, I shave the wound and we do it in the operating theatre. I think if you do it the night before, you get little microabrasions which are likely to lead to infection. And I only shave the area where I'm going to make my skin incision, so like an inch wide down the front of the knee.
Thank you. I think we should now.
For the next speaker.
I'd like to call up Anand. Where is it? He's a good friend of mine, has trained in Delhi, then trained in London, and now settled in Dublin. He's going to talk to us about his last experience of infection and treatment of infected knees in a single stage. Off to you, Anand.
Yeah, just as it opens up. Just to catch up on a few things. Just let's see if this opens up. I should be there. Okay. I'd like to thank the chairperson and the judge, and also like to Mr. Maria, Mr. Gupta. I'd like to also thank the IOA for inviting me down. As Ajay is a good friend and he's talked a lot about this, I like to say that on my colleague's thing on using drains, somebody did ask this question. I use tranexamic acid and you can reduce use of drains completely. I moved out of using drains for total hip replacement many years ago, and I sparingly use drains for total knee replacement. Tranexamic acid there are a lot of papers on it. It's given at 15 milligrams per kg body weight, and we use 1 gram stat dose 30 minutes before we start a surgery, and we sometimes repeat a dose 6 hours or repeat a dose at closure, depending on what protocol you want to use. This was khula hota na?
ये खोला हुआ है, आने नहीं, स्किन पे नहीं आ रहा है.
Is it?
स्किन पे नहीं आ रहा है, नहीं नहीं.
Sorry.
100 में है आपका.
The other speakers have given their talks for loading.
Beforehand.
नहीं ले रहे सर आपका लैपटॉप.
Dr. Kapil, are you here? Have you given your talk?
आउटपुट शो नहीं कर रहा है.
आप एक काम करें. Can somebody else start? And John, you want to go ahead?
पेन ड्राइव्स मुझे दे दीजिए लैपटॉप में.
Invite John Collins. He's a senior lecturer at Kiel College, also professor of surgeon at St. Thomas Hospital, London. A key friend of mine, he has worked as a knee designer for quite a few different companies and for revision knee systems.
I'm still poor.
And the main research is in petrofemoral joint replacements and two-stage total replacements. He's now also working on designing a new patella cutting device, which I'm sure we'll hear about. John, over to you.
Okay, thank you. Lovely. Wonderful. Just get my stop clock going. Thank you very much, Ajay, for that very kind introduction. I'd also like to thank the organisers of this wonderful conference for inviting me to come and speak. It's a great privilege. As Ajay said, I'm going to be talking to you about treating an infected TKR using a two-stage procedure. Let me see here. Now, first of all, I think it's important to define what we mean by an infected TKR. We see lots of total knees, which are a little bit red, a little bit swollen at 2 weeks. And I think the important thing is you should avoid using antibiotics until you've actually proven there is an infection. So early infection up to 6 weeks, it's possible to save the prosthesis if you do an early washout, either open or arthroscopic. If you do an open one, always change the polythene on the tibia if you can, if it's not a monoblock. However, after 6 weeks, it's really a waste of time to consider doing anything like a washout arthroscopically or open. And we would then define that as a late infection. And I think then if this is established with microbiology, then the prosthesis has to be removed. So definition of infection, where you get pain, swelling, redness, a significantly raised CRP, an aspiration would show an increase in white cells. Hopefully you would culture a bacteria, particularly if you culture it for long enough. And the other thing is, don't just use swabs, take fluid and put them in blood culture bottles. Otherwise, a lot of the time you'll get a false negative. Histology is very useful if you've got a good histologist to look at the number of polymorphs in a high power field. And bone scan is sometimes useful, but it's questionable. It's very difficult, I think, on a bone scan to differentiate between an infected loosening or an aseptic loosening. But if ever in doubt, always err on the side of it being infected if you're not sure. So with the gold standard, I think now for diagnosing an infection is doing arthroscopic biopsy, or if you want to do open, you can. But I now do an arthroscopic biopsy. I take 5 biopsies, 2 from the suprapatellar pouch, medial and lateral, 2 from the medial and lateral gutters, and 1 from the area of the fat pad. And that's sent off for both histology and culture. You can use pituitary rongeurs. They're very useful to do this. And they should be cultured for at least 14 days. So what's the treatment options? Well, in a few patients, elderly patients, those who are too infirm for further surgery, you may consider antibiotic suppression. And I have one old gentleman who's got a wound which weeps every now and then when it starts weeping, we put him on an antibiotic. And he can still walk, he can bend the knee, but he's too unfit to undergo any further surgery. Arthroscopic open debridement, as I've said, is useful before 6 weeks in about 30% of cases. And then we come on to explantation, and this is where it's divided into the 2 different types, 1 stage and 2 stage. Failed cases you may need to consider arthrodesis or amputation. I don't think resection arthroplasty is an option in any patient, personally. Now, there are some proponents of 1 stage surgery who say that this is the gold standard, particularly my friends at the Endo Clinic in Hamburg, who do all of their revisions for infection in 1 stage. But one has to say they've got a fantastic unit which is set up to do this. They have a histologist and microbiologist who does nothing else but look at their infected specimens. They can do frozen sections and slides at the time of surgery. But the problem is, if you go in to do a 1-stage surgery, you have to cement the stems, and it really means there's no second chance. If you get a reinfection, the next operation is a significantly difficult procedure. You can't go in for a second debridement. The whole thing has to be removed. And the other problem is that you can't, at the time of surgery, often give the relevant antibiotics if you haven't got cultures and sensitivities. So the 1-stage revision is radical debridement, frozen section at surgery, completely cement the stems, and use a constrained prosthesis. Not recommended if you don't have a bacteriological diagnosis at the time of aspiration or biopsy. Also, not very useful if there's bad skin problems. You may need to get a plastic surgeon involved to do a flap, and that's always done best with a two-stage procedure. So the two-stage revision, what we now call the gold standard. Cement spacer blocks have been used for a long time, but now have been superseded by articulating spacers, either made out of bone cement or by using the prosthesis you've taken out. Now, this can only be done if you have an autoclave on site. And in the UK now, this is becoming less common, so we can't do this. The prosthesis is removed, the cement's removed from it, and it's put in the autoclave and sterilised. This includes the polythene. Then you can then put some cement on the back of the prosthesis and loosely cement it, if you can understand what I mean, into the femur and the tibia again. This means that the patient then has a spacer which they can move during the next 6 to 8 weeks, and at the time of the second stage, it's easy to remove. And results have shown that this is significantly better than using a fixed spacer. So with one versus two stage, obviously with one it's a benefit because there's only one surgery. With one stage you must cement the stems, two stage you can use press fit cementless. You have to use a constrained prosthesis in one stage. With two stage you can usually go for a PS or a semi-constrained, but I tend to use a rotating hinge in most cases. The antibiotics locally are high in the two stage because you know exactly what the cultures and sensitivities are, and you can add these antibiotics to your cement. And it doesn't matter if that weakens the cement, it's only a spacer, it's going to be removed. The bacterium has to be identified if you're doing a one stage. It's not so important at the two stage because you can culture the sensitivities during the gap between the first and second operation. However, the success rates are similar. In the two stage, most of the literature shows the success rates of 90%, whereas in the one stage, 70 to 80%. However, how do we know this? If you look at the literature, there's very few papers on the left-hand side about one-stage revisions, whereas on two-stage there are many papers that have been published. Spacer blocks, the articulating spacer, as I said, is an advantage. It needs to be autoclaved and then loosely cemented back in place, and there's an example of one there on the right. Cement spacers is something I use. The company supplies a mould. They don't supply it, they sell it to you. And then you fill that with a low viscosity cement, and you make a cement spacer which then can be inserted in the knee. These are very functional, and the knee can bend. I have one old lady who's had it now for 10 years, and she will not let me do the second stage because she's so comfortable. With antibiotics, it depends on what you use normally, but with a two-stage you can see what the bacteria are sensitive to and add those antibiotics to your cement. Post-operatively, we tend to use ticaplanin and rifampicin for 1 to 2 days and then follow up with an oral antibiotic which is relevant to the culture. Post-operatively, they get daily physiotherapy. They are encouraged to bend the knee and to partially weight bear with crutches. And then reimplantation can then occur at 6 to 12 weeks later, sometimes later if the infection has not been cleared. We did a prospective study some years ago with 33 patients. There's the demographics. The spacer time on average, because we used a mobilizing spacer, was 15 weeks. Mainly Carag-negative Staphylococcus staph aureus. We eradicated the infection in 91% and only 3 patients had a reinfection. Now, if you look at all the literature, that's roughly about the same sort of figures you'll get from most of the papers, between 73 to 100% in most of the papers which look at two-stage revisions. And there we are. Here's a case that I just brought up. A 58-year-old man with 3 prior surgeries was on antibiotics for 14 months before he was referred to me. We did a 2-stage revision. This was a methicillin-resistant staph epidermidis. Had an excellent result, and he's 32 months post-op and has had no evidence of reinfection. So in summary, I would say that 2-stage revision remains the gold standard. An articulating spacer allows good function, it gives high patient satisfaction, and the eradication rate is around 90%. It's cost effective and has excellent clinical results. I thank you for your attention. We've got 1 minute for questions.
Revision, if the patient comes late to you, we usually see lots of bone gaps or defects.
Yeah.
Would you like to fill this defect with a graft or with the help of some sort of wedges?
I'm very keen on using trabecular metal cones now. I find them very useful, but I think you can use what you're used to. I think bone graft you have to be careful. I think in infected cases doesn't do well. If you've got small gaps, wedges or spacer blocks are useful and you have to use them. In an elderly patient, there's no reason why you can't use cement with a long stem. That's probably a reasonable thing to do. But the new trabecular metal cones are very useful for rebuilding the defects.
How long do you give IV antibiotics and what about the oral antibiotics?
We try and keep the IV down to 4 or 5 days. If you have to give it longer, then you've got to put in either a PICC line or some deep line, which is a bit of a nuisance for the patients. It depends on what you grow at the time of the culture and sensitivity. If you can find a decent antibiotic which is oral, I'd rather get them on oral, get them moving, and get them out of hospital.
Please go to the mic so that the others can also hear your question. There's a mic just
Early infections.
Yeah, the question is about early infections, retain the prosthesis.
If patient develops a sinus fistula,
Oh, it has to come out. Yeah, if they've got a fistula or sinus, you're wasting your time with a washout or debridement. Yeah, the ones I'm talking about, the patients you see at 3 or 4 weeks, it's a little swollen, you bring them in, you do an aspiration, and you grow a staphylococcus. Now, at that stage, you've got nothing to lose by doing a washout, debridement, or even doing an open washout, removing the polythene and changing the polythene spacers. You may get away with it. Your chances are about 30%, the literature shows. And you've got nothing to, at that stage you can do your biopsies as well, and then if you do not eradicate the infection, you then just proceed to do a second stage.
John, if I may ask a question, roughly in what percentage of your patients were you able to identify the organism?
Sorry, identify.
Identify the organism, in what percentage roughly?
With the open biopsy type, usually about 85%, most of them.
And get a sensitivity profile as well?
And get a sensitivity, yes. But very occasionally you've done your second stage and suddenly a late result comes back and surprises you, something you never had before, and then you just have to change your antibiotics you're giving them post-op.
How often has the organism been tubercular?
I haven't had one yet. None in my series. But yes, it will happen, I suppose. Good.
I think, thank you. Thanks a lot.
Call Anand back. Thank you, Anand.
My apologies. Thank you very much. Is it loaded now? Well, I would like to thank my previous speakers and, of course, John for making my job a bit easier. And I'll be talking on single stage. Well, sometimes we call this as direct exchange. You would normally find that this is much tougher. Thank you. Where would you do this, and what kind of patients would you be best doing this on? In UK, we have about 80,000 joints, knee replacements done. This is from the UK has evolved a very good joint registry, and you're able to look at about this amount. And in 2011, we had about 80,000 joints done. Surgical site infection is estimated to complicate about 1%. That's in good units. Now, the National Joint Registry has done an excellent job in bringing out a lot of other stuff in it, which if you go onto the sites, you'll be able to see. But high quality surveillance is needed because the true rate might be much more bigger than what we think of. The options, as we discussed, there are 7 options, but as we were in John's talk, we don't talk about resection arthroplasty and arthrodesis in this, but you can go for antibiotic suppression, arthroscopic washout, which can be a iffy thing. Open washout and debridement is the way to go ahead, and a poly exchange. A single stage revision or 2-stage revision. Now, antibiotic suppression, I think the Oxford Bone Unit, infection unit, talks about the DARE, where you have debridement, antibiotic and implant retention. I think Prof. Price has done a lot of work on that. The 9th Joint Registry of England and Wales said that 198 patients one-stage revision for infection, out of and 493 patients had two-stage revision for infection. Now this is the comparison done for a single-stage or a two-stage revision. Why, when you do the search, a literature search, you search at anything, and these days in Google search is so powerful that you get thousands and thousands of literature. But if you do a search on a single stage, why do you get so less number of articles? Where you can really count the number of articles, because is there that something is that you start doing and then you find that the results are not good, you're getting about 30-40% reinfection after a single stage, and you don't want to publish this? Or is there a publishing bias on it? We don't want to come out, and we only want to show the best that we have in our units, and we don't want to show what we haven't done as best, sort of. I think worthwhile looking at is, now this is of course a forest plot graph, and you see the Singer's paper. Joachim Singer he's a German surgeon. He's not from Hamburg Endo Clinic. He's from Mark Groningen. He has one of the largest published results, and they talk about reinfection rate in one stage is as less as 11%. Well, Joachim Singer's paper talks about 93 to 96%, because they have taken not only total knees, they've taken unicondylar knees also for who have got infected in that, the whole group. But when you look at, when you compare it to the other series that you have, some of them are very old and you can't really find out. Then, of course, this is, you look at the Mons A and the Mons B. These, again, the forest plot graphs, you can find that their results are pretty good. We have Haddad there, 2000, then you look at it and it comes down to more than about nearly 15%. So as we talked, when John was talking about, is he able to identify the causative organism? This is the most important thing. And what you see is, if you're able to identify the causative organism, and it should be susceptible to 2 antibiotics. If you're able to identify and it's susceptible, I think for this you need a very dedicated unit, having a clinical microbiologist and having a histopathologist. And when you look at some of the results coming out from the literature, the surgeons involved in this kind of work from Germany, Herpert and all those guys, they use 5 different blades taking their samples out all the time. So this is the way they work on. So they don't even use the same blade again while taking the samples out there. Again, Singer's work here, as I told, he's used unicondylar primary knees and he's hinged knees prosthesis. But they talk about the hinged knee prosthesis. They go back and say that it's a higher rate of infection if you use in direct exchange a hinged knee prosthesis. But some of you might ask, why would you go for a hinged knee prosthesis? Unfortunately, you have to have the full, the kitchen sink ready, because you don't know how much of debridement you'll do, you don't know how much of bone you'll take out, and you don't know how loose the routine process will. You might have to just use which will support your valgus varus stresses and strains. They found no recurrence infection in unicondylar and primary total knees. They say that 3 out of the 20 patients with hinged knee prosthesis had recurrences. They talked about the recurrences of hinged prosthesis, but they said they went back and they took out, and where they saw the debridement was that they lost a lot of bone, they went back to a hinged one and they put a hinged one, even knowing that the hinged one will give rise to a reinfection rate which is much higher. Forster's, this is of course an old paper. When we look at the results, there are 104 were available for analysis, and they looked at the revision rates. The follow-up was 5 to 15 years, and they say that no infection rate in about 73% of the patients. So this is an important one, that there should be no sinus tract. Did somebody ask about the sinus tract? Absence of sinus tract. You cannot, please do not go for direct exchange of implant if you have a sinus tract. Known organisms, gram-positive is shown to be better. The patient should not be immunocompromised. He shouldn't be Hep B, Hep C, all those things, along with previous any transplants and Izion, any chemotherapy for anything else. Absence of any bone loss. Now these guys have made it very strong that if there is a bone loss in the initial x-rays that you've taken, then it is definitely infected and you shouldn't go for, definitely it is not that you would accept it in your, as a good result. Of course, they talked about 12 weeks of antibiotic therapy. These are some of the references for everybody to have a look at. Thank you. Any questions?
What do you do if you have a gram-negative body?
Yeah, it's the same, but somehow, Ajay, they've shown that the gram-positive, the results have been better. I think if you personally, if I've looked at it, two of patients with E. coli infection, and we tried the DARE technique of from Oxford, keep them on long-term antibiotic. But as soon as you stop that, because the GPs sometimes would say that, okay, you've had 4 months of antibiotic, they stop it, their CRP, ESR levels start going up and all that, and probably the patients feel that, oh, it's acting up a bit. But otherwise, I think it needs a revision. I'm just biding my time. Yeah. Yes, and more.
Do you always go in the plan B? Do you keep your spaces with you?
Yes, that's a good question. Yes, that's right. We also do the articulating one, because if you go for the soapbox, as some of my previous consultants used to when they just teach me, you put a square one, then the patient doesn't get a very good range of motion. And there's always, we find that there is more extension lag. Somehow they always develop about 5-10 degrees of extension lag. The flexion they are able to somehow manage. The extension lag becomes a bit of a problem again for these. So we always keep that ready. As I told you, have the kitchen sink ready, because you don't know. And I have been with some of the guys who say when you're debriding, you just have no mercy on the thing around it, that, oh, I need to come back and do something here. Because you de-glove, de-scrub, you get out, then the new set comes in, new draping and all that stuff, and you go for a direct exchange straight away.
One more question. If I was a patient and I came to you and asked you, doc, what is the percentage success rate in a 1 stage and a percentage in a 2 stage, and you was to be tracking up to 70 versus 90, most patients, I'm sure, prefer the 90 to the 70.
Yes, that's a very good question. Now, so we don't hit 70. It's the literature which shows that we could have up to, even some literature shows that you could have 96% as good result. Now, I tell them that you have a choice. Here I know the bacteria. I know its sensitivity. I'm going to go in and do a direct exchange. You're going to go home faster. You're not going to be on 2-stage. I'm pretty sure my colleagues in NHS will also agree that sometimes it gets very difficult to get them back in 6 weeks, because you don't have the thing arranged for 6 weeks. If they get 8 weeks, they get 9 weeks, sometimes 10, 12, it just becomes difficult. Like, I'm pretty sure some of them have come down here, the list have to be done, but difficult cases cannot be done. So, it's all, there are a lot of other issues. It is not as fixed as you might think.
One more question.
We often confuse the good results for 1-stage revision from the German literature. The endoclinic and the group, there's a big difference the way they do their debridement. They will take off all the collaterals, they will take off the distal femur and then put a hinge. So the results are far better because they do extensive debridement and they do a cemented hinge. So when we compare that, which has almost 85 to 90% success rate, to that which is 70%, is not that extensive debris and probably a normal kind of constraint knee. How we have to differentiate how Germans do it and how rest of the
Absolutely. I mean, in Europe also we sometimes look at it. I mean, I think yesterday I was talking to somebody, I said, till date nobody has been able to replicate some of the results which is done in certain centers. We all talk about AVN, Olefekat's work, and we cannot get 99% in the grade 1, grade 2, because some centers are just so good that they are, or I don't know what's there, but exactly what you said, and you said it very correctly. I said, once you go, you should be prepared that you might have to put your hands up at certain stage and say, listen, change of plan, we put a spacer, come back some other day, I don't have this, I'll have to change this to from direct exchange to a 2-stage. So no egos, no problems, put your hands up, say that, listen, I don't think so, I'm going to win here. There's nothing that, let's put it and get away and, get home kind of thing.
Thank you very much.
Thank you. Thank you very much.
Good afternoon. I am Dr. Kapil Kusresh from Allahabad. First of all, I am thankful to the organizers of this conference for giving me this opportunity to talk in front of this August gathering. And I am so sorry for my throat. For last 3 days, today I am able to speak a little bit. I have been asked to talk on new trends of antibiotic therapy in TKR. It was quite a difficult topic, but I somehow could manage to bring some material. As we all know, infection is the most feared complication in any joint replacement surgery. This may result in increased morbidity, increased revision operations, and increased antibiotic use. But fortunately, the rate of infection in hip is 0.3 to 1.3%, and in knee is 1 to 2%, not too much. So, as far as pathogenesis of infection goes, early infection results from intraoperative contamination, and the late infection usually results from hematogenesis spread. Bacteria adhere to prosthetic material and produce a biofilm. Infection leads to bone erosion and loss of bone stock. This is the pathogenesis. Microorganisms which are most common are coagulase negative staphylococcus, 13 to 36%, Staph aureus 21 to 25%. Other organisms encountered are streptococci, enterococci, gram-negative bacteria, and very rarely anaerobes. A bit about MRSA, methicillin-resistant Staphylococcus aureus, which was first described in 1961. They have extra penicillin binding protein, which results in a low affinity for beta-lactam antibiotics such as penicillin and cephalosporins. We are seeing increasing trend in MRSA infection in joints. They have poor clinical outcome because of the limited effectiveness of antibiotics. They increase the cost of treatment of infection, and they are emerging as a cause of community-acquired infection. So we are very much worried about this infection. As far as the treatment of prosthetic infection goes, it is just the revision, as we have already heard, prevention, surgical debridement with retention of the prosthesis sometimes, 1-stage and 2-stage reimplantation, long-term antibiotic suppression, resection arthroplasty, and finally the arthrodesis. AOS has recommended few recommendations to reduce risk of infection in TKR. The recommendation 1 is the antibiotic used for prophylaxis should be carefully selected, consistent with current recommendations in the literature, taking into account the issues of resistant and patient allergies. Cefazolin or cefuroxime are the preferred antibiotics for patients undergoing orthopedic procedures. Clindamycin or vancomycin may be used for patients with a confirmed beta-lactam allergy. Vancomycin may be used in patients with known colonization with MRSA or in facilities with recent MRSA outbreaks. Recommendation 2 is timing and dosage of antibiotic administration should optimize the efficacy of the therapy. Prophylactic antibiotics should be administered within 1 hour prior to skin incision. Due to an extended infusion time, vancomycin should be started within 2 hours prior to incision. If a proximal tourniquet is used, the antibiotic must be completely infused prior to the inflation of the tourniquet. The dose amount should be proportional to the patient's weight. For patients more than 80 kg, the doses of cefazolin should be doubled. Additional intraoperative doses of antibiotics are advised if duration of the procedure exceeds 1 or 2 times the antibiotic's half-life. If there is significant blood loss during the procedure, we may again have to give another dose of antibiotic peroperatively. The general guidelines for frequency of intraoperative administration are cefazolin every 2 to 5 hours, cefuroxime every 3 to 4 hours, clindamycin every 3 to 6 hours, and vancomycin every 6 to 12 hours. The recommendation 3 is duration of prophylactic antibiotic administration should not exceed the 24-hour post-operative period. The prophylactic antibiotic should be discontinued within 24 hours of the end of surgery. There is no role of continuation of antibiotics till all drains and catheters are removed. There is no evidence of benefit when they are continued past 24 hours. Now, once there is infection, the antimicrobial therapy should always be combined with surgery. The duration of infection is an important factor in determining optimal treatment. The microorganism should be cultivated before surgery by biopsy and or aspiration cultures. With an infection of greater than 1 month duration, biofilm has progressed to such a degree that cure with prosthetic retention is not achievable, then we have to resect. The antibiotics for treatment may be systemic and local. Local delivery of antibiotic can be provided with antibiotic cement bed, beads or spacers, as has been described by my previous predecessors. Local levels of antibiotics exceed those attained with systemic antibiotic therapy. The prerequisites for antibiotic for cement spacers are microbial sensitivity, it should be bactericidal, it should be heat stable, and it should be in powder form. The commonly used antibiotics are gentamicin, tobramycin, vancomycin, and fosfomycin. Systemic antibiotics, the combination therapy is more effective due to the emergence of resistant organism. The addition of rifampicin to antibiotics regimens for treatment of prosthetic joint infection has been shown to be beneficial. The effective treatment modality in penicillin susceptible streptococcal prosthetic joint infection treated with prosthesis retention and intravenous penicillin. Once daily ceftriaxone followed by oral amoxicillin and rifampicin combination is very effective. The main advantage of the combination of quinolone with rifampicin is their excellent bioavailability, oral administration, and serum levels compared to those obtained during IV therapy. Both drugs display high levels of intracellular penetration and activity against intracellular staph species. Gemerli and colleagues assessed the role of rifampicin in 33 patients and reported that the combination of rifampicin and ciprofloxacin achieved a cure without removal of the implant. Linezolid is an attractive agent for bone and joint infections due to its excellent oral absorption, bone tissue penetration, activity against multi-drug resistant gram-positive bacteria, and good results in experimental models when combined with rifampicin. Pseudomonas and MRSA, prosthetic and bone joint infection remain difficult challenges in this present scenario, and two-step exchange revision remains the rule. Brocchi utilized a combination of ceftazidime and cephaloxacin in infection with Pseudomonas aeruginosa and achieved a cure in 9 of 9 patients without removing the implant. For MRSA, vancomycin is first choice. We can use it in beads or cement spacers also. Continuous IV outpatient perfusion of vancomycin with steady state plasma level of 25 mg per liter for several months has been used with success. Teicoplanin administered once daily for prolonged period also to be efficacious. Aminoglycosides are not ideal for infection resulting from MRSA. Sometimes we use chronic suppressive therapy where prosthesis retention with non-curative intention is required. It includes patients treated with monotherapy or minocycline rifampicin combination. The objectives are to control local symptoms and to reduce progression and the need for surgery. Long-term toxicity to antimicrobials should be considered, especially in the elderly. Success rate varies between 23 and 86%. Co-triamoxazole appears to be an interesting option because of the low percentage of staph strains resistant to it and the wide experience with prolonged therapy. Now, the duration of antibiotic therapy, the treatment duration significantly depends to a large extent on the surgical method applied. In the case of two-stage exchange, 6 weeks of antibiotics in an implant-free interval followed by further 6 weeks of antibiotics is effective in most cases. Prolonged treatment, 3 to 6 month duration is required in case of one-stage exchange or a two-stage exchange with short implant-free interval. and in the case of debridement with retention of the implant. Lifelong suppressive therapy is sometimes needed in selected cases. So, the take-home message is the prevention is ideal. Prevention of infection is the key to a successful joint replacement surgery. Success in the treatment of infected process demands the best surgical strategy associated with optimal antibiotic therapy tailored to the individual patient. More conservative surgical approaches such as one-stage revision and debridement without prosthesis removal are now more frequently utilized due to the availability of good antibiotics. Improved antimicrobial combinations using optimal pharmacokinetics for prolonged periods have led to higher rates of cure. Thanks for your attention.
Thank you, Kapil. Do you have questions here?
How many days will you pick up planning only use for prolonged?
We can use it, but we have to be careful for their toxicity. We must assess the renal and the hepatic toxicity. They are safe, but normally we prescribe only for 3 to 5 days. But in these cases, we have to continue for a bit prolonged period. So we have to keep an eye on liver function and kidney functions. We can give up to 3 to 4 weeks. Yes, IV in outdoor basis. OD doses. OD is convenient, so it is convenient to use.
Kapil, I want to ask a very technical questions. In our scenario where we operate, you said you give antibiotic for 3 days, they will stop. Suppose my patient become fever after 7 days. What is your planning? You start re-antibiotic again, or you want to give?
Yes, that is a very good question, because practically speaking, we are very much afraid of stopping antibiotics just after 1 day, and particularly we have to keep a very strict eye on the patient's clinical picture, the pain, the temperature, and the blood counts, CRP. But since the CRP and blood counts are usually raised, so it is not very good criteria for infection. But once if the patient is having some discharge or local signs are not good, the ideal is to take him to the theatre and to open it, thoroughly clean it and change the insert, and again institute antibiotic and take the culture. This is the ideal protocol, but people normally if keep aside the theoretical part, normally patient usually try IV antibiotic 1 or 2 days. If the symptoms do not subside, then because most of the people are afraid of doing immediate surgery in a patient who has just developed fever and having doubt of infection. So practically speaking, 1 or 2 days of IV antibiotic, if the things are not settling down, you must take him to the theatre and just inspect.
After infection in the bone, usually said that there should be given IV antibiotic for 6 weeks of session.
Yes.
In practical setting, we find it very difficult.
Yes. That was the question I was asking him actually. Ideally, the patient should get IV injection, but in our scenario, the patient cannot be admitted for so long a period. So, for initial 2 to 3 weeks, if the IV antibiotic is being given and the symptoms have subsided, we can switch over to oral antibiotic, and the oral antibiotics are also quite effective, and bioavailability is good, like linezolid and rifampicin and quinolone combination. And moreover, we have to depend on our culture sensitivity. If we have got only IV antibiotic sensitivity, then anyhow we have to continue with IV only.
Maintaining the IV for 3 weeks.
It's very difficult. We have to give this.
Are you putting central lines?
Yes, yes.
If I have to continue antibiotics for beyond a couple of weeks, after 6 weeks, I'll use a central line. You can't possibly have antibiotics going on for central line.
One last question.
In MRSA? Daptomycin. Actually, there was talk of daptomycin in literature, but purposefully I did not keep it because we are not using it. So since I don't know much about it, so I have skipped over it. But in literature, daptomycin is certainly there. Phosphomycin is again there, but I am not familiar with.
Yeah.
I just want to know in this scan, how many people have microbiologists who are units and decision making? Yes, specifically microbiologists and units.
So it's obvious it's very few. And we do have constraints over here. Okay, female. Thank you, couple. If I may suggest to take home one or two take home messages for some of the surgeons who raise their hands, otherwise, one is get your tunicas sterilized, stop using staples, and maybe consider usage of rifampicin more often. Few things which I would definitely suggest. Some of you may have might change your protocol once you leave this hall. Thank you.
Okay, we've got time for the next session now. So I'll pass on the next chairpersons. This is John Hollingdale and Dr. A.S. Prasad.
We're going to be talking about total knee replacement, cruciate retaining, evidence-based. Dr. Krishna.
You better be here.
No, not Krishna. No?
He's going to Jim.
Okay. Let's go on to my good friend, Mr. Chinmay Kuntan, a sample orthopedic surgeon at Imperial College Group of Hospitals, Mary's and Mary Cross. Jim is going to talk to us about TKR cruciate substitute.
Thanks very much, John. I'll turn it on. Thanks very much, John. And in fact, it's rather fortuitous that I'm speaking first because I'm actually going to compare TKR with posterior stabilized and cruciate retaining. So as we go through this talk, where I'll progress through the normal kinematics of a native knee, and then what we see with the cruciate retaining and the posterior stabilized in the lab, followed by how they function in a patient and survivability, we'll go from a position of knowledge and optimism to one where we think, not quite sure, need more evidence. Our lab at Imperial College is actually next to the Natural History Museum, where the skeleton of this creature is housed. And it was thought that this was our ancestor 300 million years ago that we evolved from. And this slide is really just to remind us that it's taken 300 years of natural selection for the knee to evolve into the organ it's developed into. And for any inventor, surgeon, or company to claim that either chopping out to cruciate and leaving one intact, or to have a plastic peg in a metal box is going to reproduce 300 million years of God's creation, I think is optimistic to say the most. This is really what it's all about, the differential femoral rollback. In extension, the contact point of the femur is anterior, and as the femur flexes, the contact point becomes more posterior, and that's called femoral rollback. And that was the principle of the 4-bar linkage that was proposed in the 1970s and 80s. In the 1990s and early 2000s, further research showed that actually the medial compartment rolls back slightly less than the lateral compartment. And you can see in this slide here that I borrowed from AJ that the medial compartment, even in flexion, is relatively anteriorly positioned in terms of contact points, whereas the lateral compartment moves posteriorly. So there's a differential femoral rollback as the femur flexes. And this is what most prostheses are trying to reproduce. And the principle behind PCL retention is that the PCL acts as a sagittal tether that allows this differential femoral rollback to occur. I was hoping that we'd have the talk for the cruciate retaining before mine, so I'm going to assume some knowledge here. But the cruciate retaining, whilst theoretically it provides differential femoral rollback, several studies have shown that the PCL is not normal in the knee that we're replacing, both histologically and biomechanically, and also because the ACL is sacrificed, so you've lost the 4-bar linkage. So it's by no means a normal set of kinematics in that knee. And this is a fluoroscopic study showing that this is actually where the femoral contact point should be, and the PCL is, the femur, or rather the tibia, is consistently posteriorly subluxed during the whole flexion range in a cruciate retaining knee. In addition to that, you can have this, delayed rupture of the posterior cruciate ligament, and that's a scary phenomenon that will need revision. And this is all because the PCL in the native knee is normal and in the replaced knee is not normal. So this has led some commentators, in particular Nazaki, to suggest that the soft tissue balance can have a significant effect on the kinematics of a sagittally constrained posterior cruciate retaining knee, because it varies under surgeons. And what that really means is it depends on how you put it in, as to what kind of result you're going to get. So what about the posterior stabilized? The principle is the Kalaman post. So the post here is preventing that tibia from sagging back posteriorly, but it also prevents anterior subluxation. And that is supposed to provide, at least in the lab, this differential femoral rollback. Although you'll get the rollback in both compartments equally, in almost all prostheses. Some studies have shown, in particular, there are two very good randomized trials that have shown that in addition to